So, welcome to the National Symposium of Glaucoma of the APAO AIOS 2025. And I'm the moderator, Dr. Amit Porwal, and we have our chairperson, Dr. RK sir, Dr. Pandav sir, Dr. Ramanjit madam, and Dr. Chandrima Paul ma'am. And we have 8 talks. We are having each talk of 8 minutes, and so that we can have a good time for discussion. So, without wasting much time, we'll start with the first talk by Dr. Sushma. She's going to talk on update on glaucoma therapies, what's new and what's on the horizon.
Very good morning, and thanks Amit and APAO for the opportunity. Although it's a difficult task to complete update on glaucoma therapies in few minutes, I'll try my best. Well, I'll talk in these 4 things that in segments that what about newer drugs, the drug delivery systems, gene therapy and neuroprotection, and road to next generation. Well, we do know that IOP reduction is possible by these 3 mechanisms, and we have age-old drugs who help us do that, largely decreasing aqueous production and increasing uveoscleral pathway. Few drugs also increase the trabecular meshwork outflow. And now we are looking at the newer drugs. Well, the newer drugs in the market are triple action Rho kinase inhibitors or ROCK inhibitors, they're popularly called as. They're supposed to work by all 3 mechanisms by increasing outflow, reducing fluid production, and lowering episcleral venous pressure. They have been used for endothelial healing in Fuchs endothelial dystrophy with our cornea colleagues. They are supposed to have neuroprotective, vasoactive, and anti-fibrotic activities, although it looks too good to be true, but then this is what the mechanism of action is. And most common side effect is conjunctival hyperemia, and both these drugs are available in India, Ripasidil and Etrasidil, and we've been using them. Now, the next on the line is Rho kinase inhibitors and prostaglandin analog combination. Those are fixed combination with etrasidil 0.01 and 0.02%. There have been studies to tell us that the reduction, IOP reduction is as good as 30% or more. And there have been 2 trials, Mercury 1, 2, and 3 in Europe for safety and efficacy of these in POAG and OHT patients. So the combination does improve the compliance as well as efficacy. Another drug on the market is latanoprost Bunod. That is nitric oxide donating prostaglandin analog. So prostaglandin part of it, that means latanoprost acid binds to the FGA receptor and increases uveoscleral flow. And the nitric oxide causes vasodilation and smooth muscle relaxation, and that's how it works. The other one is EP2 receptor agonist, that is OMDI 0.002%. Well, for this, the trials have been there to establish non-inferiority as compared to latanoprost. Not available in India, approved for use in Japan, Singapore, South Korea, and these areas. Coming to the drug delivery systems, there are different ways the drugs can be delivered in the eye, which can be sustained release so as to avoid the topical regular installation. So punctal plug delivery systems were the first to come in picture. So these are the plugs that are used in dry eye patients, so they're close to the eye. So travoprost and latanoprost punctal plug delivery system have been explored. However, there are possibilities of epi4 irritation and not so constant drug release, so they've not been very popular. They are pharyngeal delivery systems like rings, which can be put in the pharynxes, and the drug release happens by diffusion, dissolution, or erosion. And here also, bimatoprost ocular insert has been studied, and also timolol and brimonidine have been useful, but still limited to animal and preclinical studies. Contact lens delivery system, because the most common thing that we use in the eye is contact lens, so drug-eluting contact lenses have been explored. And again, there are certain risks and not so regular release of drugs, so they have not been very popular yet. There are preclinical and animal model studies only yet. Similar to periocular drug delivery systems, where we have nanospheres, liposomal and gel implants, particularly latanoprost, that has been injected subconjunctivally. In rabbits, it has proved to be okay, and we are waiting for further studies there. So the couple of implants that are intracameral, which have become useful, are bimatoprost implant by Allergan, which has been used for POAG and ocular hypertension. And these Artemis trials have told us that they have efficacy equal to timolol, basically non-inferior, and the amount of complications that we've had is 6%. Similarly, another one is AIOS by the Glaucoma company, which is an implantable device and has travoprost. This has also been proven to be non-inferiority as compared to timolol twice a day, and has demonstrated -6 to -8 drop at 12 months. Again, there are certain side effects like inflammation, macular edema, pigmentation, and even endophthalmitis because they require to be implanted intracamerally. The gene therapy and neuroprotection, largely the criteria is we can use a neuroprotective agent only if we have specific target receptors. We have lab evidence of resistance to injury. They are available at the optic nerve site for pharmacological concentration, and the neuroprotection is proved in randomized control trial. However, we do not have any such product which can be directly used, which fulfills all these 4 criteria. However, these are the neuroprotective agents that are being explored, that is ginkgo biloba, NMDA receptor antagonist, citicoline, melatonin, and saffron. And similarly, certain vasodilators like calcium channel blockers and carbonic anhydrase inhibitors. These have some evidence of dilation of ocular blood vessels so as to promote the ocular perfusion and have some benefit in terms of neuroprotection. There have been certain non-viral gene therapies in glaucoma like lipid nanoparticles, small interfering RNA, and short hairpin RNA, which can be useful for silencing specific genes. There can be disruption of aquaporin 1, that is again a ciliary body protein involved in aqueous production, and AAV gene therapy has been proved in many animal models. A little about progress that we can look at the levels of biomarkers. So that's the work that we had done in terms of looking at whether there are certain biomarkers that can be useful at the trabecular meshwork level or the retinal ganglion cell levels. So what we did was almost 143 glaucoma patients and controls, and we divided these patients into severe and non-severe category based on VFI. And these patients were followed up for 1 year and divided into stable and progressors based on how the VFI progressed. And then we grouped the patients on the basis of whether they responded to the medication or not, and after trabeculectomy on 1 year follow-up, whether they required medications again or not. So aqueous humor of these patients were taken, and we studied some 52 biomarkers, and this was the result. So the markers that you see in white were higher in patients with glaucoma, and the one in orange were less in patients with glaucoma. When we wanted to look at the severity differentiation, so there were certain set of molecules that we found were higher in the severe group. You don't have to bother about the names. So just see that the amount of statistical significance that you see in certain molecules that were higher in severe group. And there were certain molecules which were higher in the progressors as compared to stable group. When we looked at the trabecular meshwork level, well, that means we could identify patients who would be progressors as compared to non-progressors. When we looked at the trabecular meshwork level or the drug response, there were certain molecules that were high in the poor IOP control group as compared to the good IOP control group with medication. That means response to medication can be judged, and there can be a drug in future which can improve the response to the existing drugs. And then we looked at the response to surgery, and there were certain molecules which are higher in patients who responded to the surgery well. That means we could also predict surgical outcomes looking at the aqueous biomarkers. So basically, to summarize, these were the group of molecules which were higher in severe group, in progressors. This was with the poor response to AGM and poor response to trabeculectomy. So these are a couple of molecules which are raised in all the groups. That means these were the bad guys that we can see. So higher in severe progression and poor response to AGM. So the future direction is that we can explore these molecules which are found to be associated with severe group progressors or non-responders, and we can use them in the clinic for prognostication and risk stratification. There can be mechanistical and preclinical studies to look at causative role, and then we can look at how we can use them in the clinic using a therapeutic target. So ultimately, the clinician delight would be that we could use the existing IOP-lowering drugs with the drugs which can be enhancing the effect of the drugs, or we can do the surgery with targeted modulation of the surgery so that we can enhance the effect, and neuroprotection as well. So this is the generation next in glaucoma therapeutics. Thank you for your kind attention.
Thank you, Dr. Sushma. So I think we'll take the questions after we finish the talk so that everybody gets enough time. Next talk is by Dr. Ronnie. He's going to talk about how to proceed when there's structure-function discordance and structure-structure discordance. So it's a very, very important talk for all of us. And Ronnie is going to elaborate on that.
Yeah, thank you, Amit, for the invitation, and thanks, AIOS. So I've been asked to speak on two things, and yeah, so one is structure-function discordance, and then structure-structure discordance. So what do you mean by structure-function discordance? That basically means that when your optic disc and your visual field don't correspond, you have abnormality on one side and no abnormality on the other, or your OCT and your visual field don't correspond. So if your disc looks clinically healthy with a good clinical exam, a good RNFL, and you see a visual field defect like this, or you see any sort of consistent repeatable visual field defect, then the most likely example is that there is something else which is the cause. So a normal looking disc with a definite visual field defect means you have to do a clinical exam, look for any other cause, whether it's on the retina or on the neurological or in the neurological pathway. That's something that we need to rule out. So why are we then concerned about structure function deficit? Because one of the problems that we often face is there's only structural change. And you need to differentiate between a disc suspect and a preperimetric glaucoma. So I'm going to walk you through a few examples on this. And this is an 18-year-old boy who's a young ocular hypertensive. This is what his OCT looks like. And you can see that there's some superior RNFL loss. His GCC looks fairly normal. That's his panomap analysis, which puts the macula and the RNFL together, and those are his visual fields, which are also normal. So this is somebody who has structure-function discordance, and let's put everything together. He's a young ocular hypertensive. He has a normal CCT. His baseline IOPs are 26 to 28, and he has some structural change present. So in this patient, you have to make a decision on what you want to do based on the other risk factors. Don't go by just the OCT or just the visual field or just the disc. And his risk is probably moderate. He's willing to come for regular follow-ups, and I've been seeing him for the last 18 years now. Last 15 years now, and nothing has happened to him. This is another young glaucoma suspect with a family history of POAG. And if you look at this, his discs, you can actually see that there is some amount of change. There's also RNFL loss in both eyes. Look at his visual fields, absolutely stable over almost 10 years. Look at his OCTs, started off as normal on RNFL, but further down the line, you can see a small change. The GCC, on the other hand, started showing change from the third or the fourth visit itself. So now you have a young at-risk glaucoma patient, structural change more on the GCC to start with. You put the other risk factors into place. He has a family history. He has wide IOP fluctuations and a young age, and you definitely would decide to treat. So when you're looking at structure-function discordance, this is the way you work. What do you mean by structure discordance? And this is again the same issue. We want to distinguish between a disc suspect and preperimetric glaucoma. What this means is when your RNFL is looking abnormal and your GCC is normal, or the reverse. If this is associated with a visual field defect, we are really not concerned because structure function correspondence is there. You're not really so much worried about structure discordance. But if you have something like this, where you have an RNFL defect, the visual field is near normal, and the GCC is abnormal. This is what you call structure discordance. And this is incidentally is the fellow eye of the previous example. So we did a study some time back where we looked at patients who we thought were disc suspects. So 3 glaucoma specialists assessed all the discs without any other information. And they all had normal fields, and we classified them as preperimetric or as just disc suspects. And then we looked at the OCT without the summary parameters, just the printouts and the maps, just the maps in fact, and classified that as abnormal or normal based on the pattern. And we compared this with the machine-based parameters as being classified as normal or abnormal. And we were actually quite surprised because the clinician's discrimination of normal versus preperimetric, you can see that all the RNFL and OCT parameters were statistically significantly worse in the preperimetric group, the ones that we thought were preperimetric. What was also interesting that the clinical OCT classification did as well or better than the machine OCT classification in this group. And when you put this together, the likelihood ratio of a positive or a negative test was such that if you look at only a clinical OCT which a clinician considered abnormal, you increase the chances of that patient having preperimetric glaucoma by 25%. If it was negative, you reduce the risk by 25%. So it had actually fairly good discriminative capacity when you looked at the maps more than just the numbers alone. So I'm going to walk you through a few cases now. And this is somebody whose discs look like this. OCT looks like this. You can see that there's a RNFL defect, but the GCC looks normal. So here, the RNFL defect is narrow. You can see that over there. In the more peripheral bundle, it corresponds to the most suspicious area of the disc that you're seeing here. And therefore, this is somewhere where I would ignore the normal GCC and say that this is somebody with an RNFL defect, this is somebody with probably pathology, and I would treat them accordingly. So here you have structure discordance, but you have something on the map which tells you that there may be something wrong. When you have a very narrow defect, it may not cause enough damage for you to meet statistical significance, but looking at the map is important. This is a second case, and here this is what the discs look like. There's some peripapillary atrophy, there's a bit of a tilt. This is what the RNFL looks like. And here you can see that the GCC is showing you some change. The RNFL parameters are absolutely normal. And when you look at the pano map, again, you're not seeing any connection between the RNFL and the GCC. And this thickness is annular. Annular thickness thinning is unusual in glaucoma, and I would really not be too concerned about this and leave it the way it is. This third patient actually had congenital glaucoma. He's 20 years now. He had surgery 20 years back, and this is what the discs look like. This is what his fields look like. And this is what his RNFL looks like. The right eye is fairly okay. The left eye, you're definitely seeing some defects, and both eyes, you're seeing some changes at the macula. You put this together and look at how the pano map behaves. So you're seeing something little bit on the RNFL there, and it extends, the same thing extends to the macula. In the left eye, you can see it extends to the macula. So when your pano map actually follows the same pattern, the RNFL extends to the macula, then it's more likely that this patient has an issue. You would have ignored these little defects in isolation, but when you combine it with the GCC, it's important. So it's important that you look at the combined GC and RNFL deviation map when you are instead of looking at it in isolation. So this is an 84-year-old pseudoexfoliation, ocular hypertensive, post-TRAB for the last 10 years on 3 drugs. The RNFL looks normal, the GCC looks abnormal, and it looks sort of annular, but if you look at his fields, they're okay and they've been okay over time. But what's important here is this temporal raphe sign. If you see this abrupt sort of cutoff on a GCC, that is usually indicative of glaucomatous damage because you're seeing a hemifield difference between both hemifields, and this is fairly typical for glaucoma. So when you make a decision when you're looking at structure function discordance, first rule out other causes, and then look for real discordance. When you put the pano map together, you may have a small thing on the RNFL which connects to what you're seeing on the GCC, and it's not true discordance. Whenever you're taking treatment decisions in these patients, don't base it only on the imaging. Look at all the other risk factors for the patient. And if you're still in doubt, there's no hurry. Glaucoma is a slow disease. Wait, reassess, retest, and then take a decision on what you need to do. Thank you once again.
Thank you, Dr. Ronnie, for covering it up so nicely. Our next talk is by Dr. Satyan. He's going to talk on AI and machine learning in glaucoma diagnosis.
Thank you, Dr. Amit. Wishes and prayers for everybody's health and happiness. Yeah.
Can we have the slides, please?
Yeah, it's coming. Satyan Pathasarathi.
They know about it.
Yeah, it's come, I think. Yeah, thank you. So the AI and machine learning was the topic given to me. And so when you really look at the traditional methods of what we follow, we have a lot of subjectivity. And of course, the retina person says something different from the fields, and we say something different. So there is a high amount of variability, and also there is a possible human errors. So how AI can really kind of help us is to an extent it can be much more accurate, and the early detection can be possible, but it can really pick up the subtle changes, both the structure as well as the functional changes early. And also looking at the efficiency and the scalability, you can give many images where it can process it very quickly and give us the details. And also once you have one patient's details, it can really process everything and then give us what next to be done, especially when you see the kind of progression. There are different type of AI models one can really look at using it. So first and foremost is the data science. Once the data is given, there is a process called the pre-processing, and then the analysis has been done. Then there is a process called the machine learning, where we have to really teach the machine everything in detail. That is, manual extraction has to be done. But in the deep learning, the manual extraction is not much been done. So the machine does everything. that is called as something called as a CNN and RNN. That is a convolutional neural network, and the recurrent neural networks have been used. That's what we are using now. And there is a hybrid model. Both you can use the machine learning as well as the deep learning models can be used. And there is something called as a multimodal AI models. That means you have a fundus photograph, you have visual fields, you have OCT, everything can be combined and can be used to understand. So what are the imaging modalities that can be used is the normal fundus imaging by the flashlight. Then you have the CSLO images of the fundus photograph. You have the OCTs, you have the numerical data, you have the grayscale data. Everything can be analyzed in the multimodal imaging in the glaucoma AI. So looking at the features, what are the basic features that is being extracted in the AI models is when you look at the fundus photograph, you can see the CDR, the NRR, RNFL, PPA. And similarly in the OCT also including the GCL maps. And if you really look at the visual fields, the data can be separately taken up, and also the grayscale also can be used for the studying how the things are happening in the same way in the SLO also. So when you do the image processing, what are the things have been done in that image processing is the image enhancement. There's a huge amount of noise reduction will be taken care, or something called as a denoising. Data augmentation, vessel segmentation, optic disc and the cup segmentation. The artifacts are being removed, and also something called as a normalization. So as mentioned earlier, these are all the things that is been extracted when you do the AI models. So this is one of the AI models, how it has been done with the various optic neuroretinal rim, cup, everything. So this is what the model which we have used is the deep learning model. Though initially we used only the machine learning, but machine learning is little difficult because we have to teach the machine every time. There is a manual extraction has to be done. So the deep learning we are using, and also the transfer learning. So the challenges are there is a variability in image quality because there are different machines, different technologies are being used. Some people use the RGB, some people use only the RG. So there are various technologies. So it is very difficult to process by different image qualities. So the model level challenges are very difficult to process everything in the same way. It cannot be done in that way, but the AI really helps to an extent. There is something called as a explainable AI model also. We'll just discuss that quickly. And looking at the transfer learning technology, it is the each image is being extracted. Cup is extracted separately, disk is extracted separately, and you can see that everything is been isolated by the ResNet 50. So that is what we have used, but it is not the best of the technologies that we have found, even though we know that we have the best of the qualities by the specificity and sensitivity. It doesn't mean anything to us actually. It is not that great, though the specificity and sensitivity appears to be good. But what we really need is to look at what is the real good explainable AI. That is another model. And there are a lot of regulatory complaints because there is a lot of safety, legal and the ethical standards has to be followed. We need to see how the bias can be reduced, and also the seamless integration is another biggest problem that we face, because we cannot just combine all the machines together in this way. So, and understanding by the doctor also is another area of concern, because whatever the machine says, it is not that you just go and do everything. So this is how the image processing and AI, how you can just go as a cycle, and then you finally give it to the patient of what it is. So this is one of the other models which we have taken up recently, is called as a AXI. So if you have the fundus photographs like this, where it is completely dark, we can extract completely, and then you can see how the image quality is coming up. So this is what we have been doing now. So it looks quite promising, but we'll have to see how far we can really do it in even when you have the images very poor. So this is what we have already published and presented in one of the AI conferences. We want to really acknowledge Dr. Avanti Bindu from Amrita Institute of College. So is that AI has reached its potential, but still it is not reached, but definitely it has gone quite deeper. And I think sooner we will be having a little better models to be studied, and we can really use it. But as of now, the AI model seems to be better diagnosing than what we all can do at least at this point in time. But we have to see what the future is. Thank you.
Thank you, Dr. Satyan. We have few chairs in the front. For those standing behind, you can come here and occupy the front chairs. And we will be distributing the GSI guidelines at the end of this session in a pen drive to all the attendees. And I welcome Dr. Benjamin. Please come and have a chair here. Dr. Benjamin? Yeah. Our next speaker is Dr. Sirisha Senthil. She's going to talk about have light, zap, or mixed trials changed my clinical practice. Dr. Sirisha.
Sirisha Sandhu.
Dr. Sirisha Senthil.
405 दिया है. Go to the previous. So does the next one want to start so that we don't waste time? That one.
Nahin, nahin. Yeah, we'll take the next speaker. So we'll have Dr. Tanuj Dada, sir. So he's going to speak on what factors besides conventional IOP delivering should I discuss with my patients. So this is very, very important, especially in the current scenario, because yoga has become so popular, lifestyle changes have become so popular. And Tanuj sir is going to highlight how we have to answer the questions of these patients. Over to you, sir.
Can I have my slides, please? Good morning, everyone. So I'll be covering an important issue, what factors to discuss with your patient other than the conventional IOP lowering. And this is very important because you're often faced with this situation, apparently well controlled but progressing glaucoma patient. And it is important to establish that all the trials done for glaucoma, even though the target IOP is achieved, still a large percentage of patients continue to progress. So what are we missing? The first issue is that when we do office IOP, there is a very high chance that you miss the IOP spikes which are occurring early morning and late night. And this is very important that you explain to the patients that those who are progressing despite an office IOP which is controlled, that the IOP spike may be missed. So such patients, you need to do a diurnal, taking into account early morning or late evening night IOPs. The second very important factor is what about the perfusion pressure, which drops at night. And this is one of the profiles of our patients admitted with the diagnosis of normal pressure glaucoma. But you can see there is a variation in the IOP, high IOP occurring at night, and that is a time when the blood pressure is falling. So this is missed in the routine checking of the IOP and the blood pressure. So it's important to understand that nocturnal hypotension is one of the risk factors why the patient is progressing, and a mean arterial pressure which is 10 millimeters below the daytime pressure is a significant risk factor which points that the patient may progress. And another thing which practically you can discuss with the cardiologist is that their antihypertensive medication, instead of taking at night or evening, shift to the morning if the patient is progressing and there is a nocturnal dip in the blood pressure. Another thing to discuss with the patient, especially if they're obese, is that many patients, their relatives may complain that he is snoring at night, and this is the outlier because these patients may be having a sleep disordered breathing, and that can lead to increase in intraocular pressure. So there is a high prevalence of this sleep disorder breathing in patients of glaucoma, and it's other way around also that this is directly linked to glaucoma. The good thing is that there is a obvious surgical treatment available for these disorders. These patients, if you refer to ENT, they can cure this disorder and the intraocular pressure also goes down. Just a word of caution, you should know that these patients are often put on CPAP therapy, which itself can lead to an increase in intraocular pressure, that the treating physician should be aware of this fact. Another thing which has come to be highlighted in the recent year is sleep positions. So if you get a patient who has got a asymmetric visual field loss, which is advanced in one eye, it may be prudent to ask the patient to not to sleep on that side, sleep flat or on the other side. And especially they should not put the arm with the eye, because if the arm is pressing the eye at night in the sleep position, so that can be very deleterious for the glaucoma, because it can lead to rise in intraocular pressure. Some things we often miss, like I missed in this patient. This was my long-term follow-up, a retired Army general, and suddenly one day he came with very high intraocular pressure. I had no clue why the IOP has risen, and reluctantly, a relative told me that he has been on this medicine for urinary incontinence. So in elderly people, whenever they come with high pressure, please check the list of medications they are taking, and you have to Google some of the medications, because you are not be knowing that these medications can lead to intraocular pressure. So any medicine which is affecting the CNS and causing changes in the sympathetic, parasympathetic outflow, especially for prostate and all these psychotropic drugs, they can have. Even the anti-allergic drugs, which we commonly give, like Allegra, they can also have a induce an angle closure and cause a sudden increase in intraocular pressure. Now, what are the modifications? There was a very nice talk yesterday by Dr. Shanlin about the summary of the lifestyle changes, and this is becoming increasingly important because there is a resurgence of lifestyle disease. So I think what you can recommend is that regular aerobic exercise, at least half an hour a day, even brisk walking is sufficient. Meditation and relaxation techniques I'll just come to in a minute. Any form of leafy vegetables have high nitrates that can itself reduce the intraocular pressure. And what you have to warn the patient, those who have a family history of glaucoma, high caffeine intake, that means more than 2 cups of caffeine a day, may increase the intraocular pressure. Some of the professions like swimming, where they use swimming goggles, or performing head-down yoga postures, and using high-resistant wind instruments like trumpets, and of course, weightlifting in the gym. If patient has glaucoma, then these activities can cause a rise in intraocular pressure. You should be aware and ask the patient about the specific profession that he is in. So this was a very nice study that patients who were sedentary, if they start at least 40 minutes of exercise 4 times per week for 12 weeks, there was significant reduction in the intraocular pressure. So this is akin to giving a non-pharmacological therapy like an eye drop. So you can counsel your patients about this. So this, of course, you must warn the patient, especially glaucoma patient, that not to do head-down yoga postures that can lead to elevation in intraocular pressure. And some of the people come to us wearing a very tight necktie, so this can falsely elevate the intraocular pressure when you're checking in the OPD, and it's not recommended for glaucoma patients because it can increase the episcleral venous pressure and lead to a rise in intraocular pressure. One thing which we don't discuss with the patient, if they have got inferior field defects, especially bilateral, then there are risks to society, because not only are they at risk for motor vehicle accident, but they are more likely to be at fault. So because they're not able to see the objects, and this is also a risk factor for a hip fracture. So you must counsel the elderly and their relatives that not to keep any loose wires or furniture in the house, because these people can trip, and that can be very deleterious for the health. Finally, there is a very important link between stress. This is a blinding disorder, and stress can definitely lead to increasing intraocular pressure, both for normals as well as glaucoma patient, because it causes rise in cortisol, and glaucoma patients are already steroid responders. So this must be explained to the patient. The second thing which is often missed is that many of these patients with normal pressure have an autonomic dysfunction, which you don't come to know unless you test. This is one of the patients who was progressing, and in our laboratory at AIMS, we found that the autonomic function was deranged with a low heart rate variability, indicating sympathetic overactivity. So such patients can progress faster, and these are risk factors of why glaucoma is progressing. So autonomic dysfunction, there is no pharmacological therapy to reverse this, but just with 5 days of meditation with slow breathing, you can reverse the autonomic dysfunction in a glaucoma patient, especially if it's progressing, because slow breathing causes changes directly in the occipital cortex as well as the olfactory bulb. So that modulates the autonomic nervous system. So this is important to discuss with the patient. So just by breathing 365, 3 times a day, 6 breaths per minute for 5 minutes can lower the intraocular pressure. And you can counsel your patients to do at least 15 to half an hour of meditation with slow breathing that reduces the intraocular pressure. You can even use it for ocular hypertensive. So my take-home message is that don't treat glaucoma just as an eye. You need to optimize the health span of the patient because this is a marathon. You're treating the patient for the whole life. So adopt a holistic approach to these patients. Thank you.
Thank you, Dr. Tanish, for the wonderful talk. Dr. Srisha, you are ready? There are 2 chairs empty in the front. Anybody wants, they can come and occupy, please.
Yeah, so I'll briefly touch upon a couple of these trials which are very important and then take on what we can take for our clinical practice. So primary angle closure disease is a spectrum. We know that the first stage is PACS, then it goes to PAC and a PACG, and you have an acute primary angle closure as well. Now question is, do we treat all of them similarly? Not really, because the primary angle closure and primary angle closure disease definitely needs to be treated, where studies have shown that doing a laser peripheral iridotomy by relieving the pupillary block can decrease the progression by about close to 30%. And from PACS to PAC, over 5 years, maybe 22% of the people can be reduced from converting to PAC over 5 years. So which means that the number of people that you need to treat with PAC to prevent it from developing a primary angle closure glaucoma is quite high. So there are various guidelines, and each one of them tells different things, but there is no particular guideline that we follow. In our country, we realize that there are many centers, even major centers, who've been advocating PI for PACS as well. So there is evidence today to say whether that is necessary or not. So this was the study that was ZAP trial published in the Lancet. From Gonzong Center, 6-year RCT, where they included people 50 to 70-year-olds with only primary angle closure suspect, and one eye was treated and the contralateral eye was used as a control. And that was a very significant one, and they were followed up for 6 years, and their primary endpoints was elevation in intraocular pressure, with or without dilatation, of course, they looked at, but also with dilatation, because that was a significant factor. More than 1 clock hour of peripheral anterior synechial development or episode of acute angle closure. What did they find? Without dilatation, only 2 eyes developed acute angle closure, and the rest were with dilatation, so that were 3 eyes with dilatation. And intraocular pressure more than 24 millimeters of mercury in the control group. That means no laser group was in 5 eyes, and post-laser was in 3 eyes, and peripheral anterior synechiae developed in 15 and 30 eyes respectively in both the control and in the laser peripheral iridotomy group. So what does this actually mean to us? It means that there was an absolute risk reduction over 6 years of 2.28% and a relative risk reduction of 47%. That means you need to treat at least 44 patients to be able to prevent one PACS from developing one of the changes of PAC. So I don't think that was necessary. That is necessary for us because the number of people that you need to treat will be significantly more. So what do we take home from this is that LPI is not recommended in every PACS, but there are certain risk factors that we need to consider where there are symptomatic patients with a headache or family history of glaucoma with a disc at risk, a small disc, repeated dilatations if they require because of a retinal pathology, or they come from remote rural areas who cannot travel, they possibly can be treated. Has it changed our practice? To some extent, yes, but we do have evidence to say we should not be doing a PI in PACS unless it is at high-risk eyes. The second study, this was something that I was very excited reading this because I think I will change my practice pattern based on what I have understood from this study. So this study is LIGHT trial, which is the selective laser trabeculoplasty versus drops as first-line treatment for ocular hypertension and glaucoma. So typically we use medications, and if they don't work, we may go in for laser, in open angle I'm talking about, if not surgery. And laser is not something that we consider typically as a first-line treatment for our patients, at least most of us. So we know that there are problems with eye drops, and the major problem apart from the side effects and the cost and things like that is the compliance or forgetfulness. It's not easy to comply with this medication. Chronic use of any medication will be very, very difficult. So what has the study looked at? It looked at comparing drops versus SLT as the first-line treatment for ocular hypertension and POAG, and compared the cost effectiveness as well as the compliance in these two studies. So we know SLT, I'm not going to the mechanisms, but basically what it does is because of the mechanical as well as the biological changes that it causes, it increases the outflow in patients with open angle glaucoma. They looked at the health-related quality of life as well as looked at the cost and the tolerability of the medications. Done across various centers in the UK. Inclusion was all patients with untreated POAG or ocular hypertension. Remember, they did not have medications at all to begin with. So they were treatment-naive patients who were older than 18 years of age. They did not include advanced glaucomas, mild or moderate or ocular hypertension. It was a huge trial. And they had two arms. First arm was laser first, and the second arm was the medications first. In the laser first group, if they did not respond to the first laser, then they would go on to retreatment with an SLT, that is the second laser. If not, then they would go on to add medications. Whereas in the medications group, the first line was medications, the second line was also medications, and if that did not work, they did not offer SLT, but they went on to doing the surgery or the trabeculectomy. So these were the group of patients, but what was interesting and what was also nice, and possibly we would do that in our practice as well, as was the amount of IOP reduction that you would expect in a mild, moderate, and severe disease. So severe disease, of course, they did not include, but the end point was also different across for ocular hypertension as well as for POAG. They did not find much difference in the health-related quality of life between the two groups, and one of the reasons that the authors had quoted was that none of these patients, when in the laser group, had medications prior, and hence they do not know whether there was any problem with using long-term medications, whether it was the side effects with the topical medications or difficulty in remembering to use the medications. They were not aware. So to begin with, they were offered laser, and to begin with, they were offered treatment. So they were not switched, hence they did not know the benefit or the side effects of the other arm. Possibly that's why they did not find much of a difference is what they have told. And as regards to the control of the disease, the first panel here is for the medications group, and the second one is for the laser group. The treatment escalations were a little bit more for the medications group as was expected. Disease progression was a little bit more in the medications group compared to the laser group. Trabeculectomy was required because, again, remember the way the study was designed, trabeculectomy was required in 11 eyes, and trabeculectomy revision was required in 5 eyes. And none in the laser group required trabeculectomy because if the laser did not work, the second laser, if that did not work, they went on to use the medications. And there was not much of a difference between the intraocular pressure as well as the visual acuity in the two groups. So at 3 years, they found 78% had followed up, 74% of the patients were drop-free at target IOP in the SLT group, and 77% of the eyes controlled with one single SLT and did not require an escalation. What was also very interesting to see was only one patient had an IOP spike among those eyes that underwent a laser. So what is the take home for me? SLT should be considered or can be considered as first-line treatment or can be offered to our patients for ocular hypertension and early or moderate glaucoma. And one thing we need to remember, even if somebody asks me, I would say that, I'm worried to give this as an option because they may not come back for follow-up. But whether it is laser or medications, they have to come back for follow-up. So I don't have much time for MIGS, but I would just move on to say that MIGS is something that we have been doing now, both in open angle as well as angle closure. And one point I would just like to highlight, if you give me 30 seconds, is the way we look at the MIGS publications today. So there is no standardized protocol that we follow. Each person gives a different way of, because they are on medications, we are looking at number of medications drop, amount of IOP drop, as well as the percentage of IOP drop. And there has been no uniformity. I think moving forward, we have to look at all of these with regards to the guidelines, at least a 2-year follow-up with a reduction of at least 20%, and based on the severity of the disease, the percentage reduction also is something that we need to look at. And has it changed my practice both in open angle as well as in certain types of angle closure glaucoma? I would say that MIGS are here, whether as a single procedure or combined with cataract extraction, they do have a good promise. But like I said, we have to individualize it and use it as per our understanding and look at not just pressure control and number of medications, but long-term intraocular pressure control and visual field changes. Thank you.
Thank you, Dr. Sirisha. We'll have Dr. Manojit Singh, sir. He's going to talk on glaucoma in special situations.
Thank you very much. My focus will be on pregnancy and keratorefractive surgery, although I'll definitely talk about few surgical procedures as well. The incidence of glaucoma is increasing in pregnancy due to late pregnancies, advancements in obstetric care, increasing awareness, improved diagnostic techniques, and management of glaucoma in and around pregnancy is a unique challenge of risk of vision loss to the mother and potential harm to the fetus or the newborn. So what are the effects of normal pregnancy on intraocular pressure? It is known to decrease and it declines further as pregnancy advances. The mechanisms include hormone-induced decreased episcleral venous pressure and lower scleral rigidity. The drugs have been classified by FDA into various categories. I think this doesn't need any elaboration. Prostaglandin analogs are oxytocic and they increase uterine contractions and they have been reported to cause abortions in animals. Latanoprost has been shown to cause low birth weight, and latanoprostine brunide is a category D drug, that is, it is quite contraindicated in pregnancy. The beta blockers are again category C drugs, and this has been tested only on oral and not on the topical drugs. But they can be considered as safe in the first line in pregnancy. The systemic use of beta blockers close to delivery may result in certain defects which has not been studied for the topical use. So the preferred formulation is in the gel formation because it doesn't lead to systemic absorption. Brimonidine is the only drug, anti-glaucoma drug, which is a category B drug, which is considered safest in pregnancy. However, it crosses the blood-brain barrier and hence can cause CNS depression and apnea in newborn and possibly secreted in breast milk, so it is contraindicated in late pregnancy and in lactation. Carbonic anhydrase inhibitors are category C drugs. The topical ones are considered safe during pregnancy. However, the oral astazolamide has been shown to cause sacrococcygeal toxemia and renal tubular acidosis in neonates. Astazolamide is therefore absolutely contraindicated in the first trimester due to its teratogenic potential. The Rho kinase inhibitors have still not been studied well. Pilocarpine also doesn't have any definitive, positive or negative thing reported till now. The preference is the first trimester is the brimonidine, safest option. Second is beta blocker and carbonic anhydrase inhibitors. Second trimester, brimonidine is the first drug. Again, beta blockers, brinzolamide, PG analogs, and pilocarpine may also be used. In third trimester, topical carbonic anhydrase inhibitors become the first line, followed by beta blockers and brimonidine. Brimonidine should be discontinued close to the end of pregnancy. Topical carbonic anhydrase inhibitors are optimal drugs for this time. Postpartum and lactation, beta blockers are and carbonic anhydrase inhibitors are certified safe, but brimonidine is contraindicated as informed already. Role of lasers. SLT and ALT are equally effective and can be used in all trimesters and probably is the best treatment during pregnancy. The micro disruptions in selective laser trabeculoplasty, they do not spread to the surrounding area and hence is considered better than argon laser trabeculoplasty. Procedure can be repeated as already said by my previous speakers. Surgical treatment, the challenges are problem with anesthesia, positioning of surgery, and potential risk of antimetabolites and the management in the postoperative complications. And it is best done during second trimester if it has not been done before planning the pregnancy. The anesthesia concerns are the altered maternal physiology, which exposes both mother and fetus to the high risk in case of general anesthesia. However, most local anesthetics are safe. So, we are used to doing full stomach cataract surgeries. Please avoid this in case the patient is pregnant. The filtering surgery is relatively high risk of failure due to young age, physiological changes during pregnancy, and because antimetabolite usage is strictly contraindicated. So Ologen is no more available. Releasable sutures are a good option, and MIGS is one thing which can be tried during pregnancy. And walled glaucoma devices drainage are reasonable alternative to treat refractory glaucoma. The post-operative precautions, cephalosporins and penicillin group are safer than the fluoroquinolones. Hometropine can be used better than tropicamide. Punctal occlusion should be advised for topical drops, and ointments and gel are preferred to minimize the systemic absorption. Thus, to summarize this, frequency of glaucoma on pregnancy is on the rise. Physicians should initiate discussion with the woman of childbearing age requiring medication for the treatment of glaucoma, and multidisciplinary approach is important. Laser trabeculoplasties are the best form of treatment. The refractive surgery in glaucoma, refractive surgeries are being performed more often, and hence, since these are done in the young people, more and more pregnant ladies, they have this. Refractive surgery is being performed at higher age, and patients with longer duration post-surgery are now presenting without previous records. Myopia is a risk factor as such for glaucoma. Post-keratorefractive surgery, the first challenge is the measurement of the intraocular pressure. The standard instrument still remains GAT for this purpose also. Pachymetry should be done, as all of us know that this affects the measurement of the intraocular pressure. Why these slides are moving automatically, I don't know. Tonopen is a handheld Mechamark tonometer, which is also considered very good for this purpose, post-keratorefractive surgery. However, the Pascal dynamic contour tonometer is the best, but it is not freely available. The effect of central corneal thickness is always there as measured with any drugs, but it's a minimum with the dynamic contour tonometer. The effect of biomechanical properties, there is decline in the measured intraocular pressure following keratorefractive surgery, even if there are no changes in the central corneal thickness. Perimetric corroboration of the structural and functional defects is important in the diagnosis of glaucoma. Multiple visual fields may be required to get reliable visual fields, and changes in the visual fields may occur quickly after LASIK and may be long-lasting. Minor changes in these visual fields may not be suggestive of glaucoma but may form a new baseline. A large blind spot, paracentral scotoma, nasal step, even an arcuate scotoma may be seen in myopia even without glaucoma. So this must be remembered in these patients. The pulse related to individual procedures. In LASIK, post-LASIK interface fluid syndrome should always be remembered because the pressure of 40 may be measured as 10. And the differential diagnosis is diffuse lamellar keratitis or microbial keratitis, and the treatment is totally opposite. So what should be done? Refractive surgeon must know these possible complications, and many patients do come for the follow-up with the same surgeon, resulting in delayed or wrong diagnosis. SMILE is relatively safer because less steroids are used. Phakic IOLs, improperly placed lens or non-performance of PI may lead to acute pupillary block. We do see unexplained glaucomas as well. However, shaping or inappropriate size can be the cause.
Can you sum up?
Okay, so I'll not discuss these secondary cases. Thank you very much.
Thank you, sir. We have our next speaker, Dr. Rangaraj Venkatesh from Arvind Eye Hospital. He is going to talk on mix in developing nations like India. How are we different from the developed world, and where do we stand in terms of results and economics?
Thank you, Amit. Very detailed topic, so but I'll try to finish in next 8 minutes. So you all know the problem of glaucoma, the burden, I would say. Now it's going to almost double in 2040. Now we've already crossed 2020, but it's more so in India. This number may be staggering by 2040. But what we understand now is, from most of the tertiary care centers, we see that more and more of mild to moderate we have started seeing, referral from primary and secondary care. Almost 36% had mild to moderate. Similar work we did a couple of years back in Pondi, just after COVID, to see 60% had mild to moderate glaucoma on presentation, which with the vertical cup-disc ratio of 0.6 in the better eye and 0.7 in the worse eye. And if they come little advanced, mostly they were older and with the low educational levels. And we all know the financial burden. I don't have to talk about it. Most of them are dependent. And if you see in the low income group, 26% of their monthly income was on glaucoma treatment in many times. Same way, this expenditure, kind of change from high income, just 0.3% to somewhere 123% for low income. And more so, there is a lot of other expenditures of travel, stay, and loss of wages when they come back for follow-up every 3-6 months to us. So many patients are now having a salt and pepper like me. Now you're seeing glaucoma at a much middle age now, coexisting cataracts, definitely a big financial burden which you see either with medications or even laser if they have some good results for a couple of years. So I'm sure we all know that glaucoma is a surgical disease, but over a year we have been moving from traps and tubes because of a lot of these issues, long recovery, a lot of challenges post-operatively, and it significantly impacts the quality of life, which is changing now with the new generation. They want a good quality of life. That is where MIGS comes. We know MIGS is there for a couple of decades, some of the devices for more than 10-15 years, and we are seeing some good results, and that's why we are saying it's highly safe. It's kind of reasonably good IOP lowering effect. And also we see rapid recovery, like cataract patient bouncing back to the regular job. This we are seeing for the last 3-4 years, and that's where I'm able to confidently say that you can now do for most of your mild to moderate ocular hypertensions, either open angle or even angle closure like Sirisha highlighted. And definitely there are some of the relative indications, even in advanced glaucoma, if they are older age, life expectancy is less, they have a lot of comorbidities, you can think of doing some of these procedures. And you all know I'm just talking about things which are just available in this country now. Zen may not be available, but it may be. But enhancing the Schlemm's canal will be the key, how we are going to enhance. So there are a lot of devices and also techniques which does not depend on devices. And you have something which is destructive for kind of glaucomas which are not manageable with all this. So whenever we are talking about MIGS, at least in the developing world setting like here and several other countries, it's either resting. Where you want to rest it, it's usually the devices, whereas we call it as ripping, where you excise or incise your trabecular meshwork for a better outflow. So resting, if you see, is kind of cost prohibitive. We all understand that we have some resting devices. We have devices coming up in the next few years in the market, but definitely they are cost prohibitive. It's not that they are not very effective. We are seeing some good effect in Indian eyes slowly in the results which are coming up. But if you see this data, where there is for every millimeter of IOP reduction, if you compare between trap, this was a study done in Middle East, but it equally holds good. Somewhere the difference is almost 10 times higher. So when we talk about ripping techniques, these are all the techniques which are there with us, which are really some of the viable options in front of us. But the point is, there are definitely, we have devices especially which are not available, and of course greater incidence of angle closures and advanced glaucomas we have to keep in mind. But adopting MIGS is another challenge. Some devices are cost prohibitive, some definitely we need more training, and also we need better infrastructure, microscopes which are good, where you can have positioning and all that to do comfortably these procedures. So it's not a big challenge, but it is a challenge in some places, but we'll have to keep working on it. So whenever we are trying to navigate through the economics, I think one technique which comes in my mind is the GATT, which all we learned from Davinder Grover. My colleague Swati is sitting here. I mean, she trained some of the colleagues in Arvind, and now most of them comfortably do this 360-degree trabeculotomy using a very less expensive phioprolene suture. It really helps in advanced glaucomas, and that's what my good friend and colleague Devendra had published. There is significant IOP reduction in 6 months. When you compare phaco GAT and GAT, if you see the GAT, the IOP is slightly higher, but there is a very good reduction. And when you combine it with cataract, it is really good. And I'm sure the results, we have to work on MIGS results on long-term, 2 years, 3 years, but whatever short-term results is very promising. This is some study on advanced glaucomas, especially advanced pigmentary glaucoma. They had both GAT and the trap group. And if you see, there was significant IOP reduction in both the groups and also significant glaucoma medication reduction in both the groups. So it really works in advanced glaucomas. Again, when you want to navigate, I think this technique is brilliant. You just bend your 25 gauge needle and you can start doing a nice incision of the trabecular meshwork. So this works, and we have a lot of good studies, again from the AIMS team, 32 eyes of 32 patients. They followed up to 12 months and found a significant IOP reduction. And if you see the success, again, more than 20% reduction was achieved in almost 62%, and the overall success you can see in 87%. But we need more eyes and longer periods of study. But one thing which we all like and admire is this hook. I have no financial interest, expensive hook, and I saw few trades having this at a low cost. I don't know how it works, so I can't comment on that still. But the Tanito hook is $5,000. But the best thing is it is reusable, it's sustainable, it goes into your set, it can go to your flash autoclave, come back, and you can continue to do high volume with these hooks. Again, a brilliant study from my colleague Devendra, where he saw the phaco trabeculectomy group and phaco group. You can see there's a significant reduction in the phaco Tanito group. Sorry, not trabeculectomy, phaco Tanito group. And then the medications also, there was a reduction in the anti-glaucoma medications. So we have some good results coming from the other parts of the India also, like how you see here, this is 30 eyes of 30 patients, where again there was a significant IOP drop, and they all had visual outcomes when you are combining with cataract surgery. So when you see the mixed device market, I'm sure you're going to see in quick in India. There are new devices coming up, and there are several devices which is already in the market which will come to India. And if you see, this is a global CAGR, cumulative annual growth. There is significant increase in the devices and the usage of these devices because the results are getting better and the complications are reducing. But this is a thing which we have to direct. So for that, we need long-term randomized control trial, looking at success rates. Like what Sirisha said, maybe 2 years, 3 years, 4 years down the line, we'll have to see some of these results. Definitely, we have to improve some of the infrastructure and training for MIGS. Otherwise, we may have a lot of devices in different places of the eye. Definitely better understanding who will, because we can tailor the surgery now. Who needs a trap, who needs a tube, who needs a mix, and all that is very important, that understanding. And finally, subsidizing, insurance or even government subsidy to it, or through the PMJ scheme. We'll have to see what really helps some of our mild to moderate so that we can surgically manage them in a better way. Thank you.
Thank you, sir. So just a small comment. The Tanito hook is costing us $5,000. Now we have one more hook available from China that's costing only $950. So it's somewhere similar like the Tanito hook. It's called the Land Micro hook. So our next speaker is Dr. Rajul Parikh. He's going to give us, we have this talk specially because this is a national symposium, and we thought we should give the due recognition for the GSI guidelines. GSI has formed the guidelines for all the comprehensive ophthalmologists and also the glaucoma practitioners. We have the guidelines we are going to distribute here in the pen drive, and people behind framing these guidelines were Dr. Chandrima Paul and Dr. Rajul Parikh. So now I invite Dr. Rajul Parikh to update us what this guidelines consist of and how it's going to be useful to all of us.
Yeah, thanks Amit. So in 8 minutes, I'll just try to cover the basic concept of the guideline. So me, Venkatesh and Kavita with the editor, and I would say Chandrima and Dr. Pandav, they were very helpful and they didn't interfere at all during the making the guidelines. And we have, these are the chapters. We had chairs, co-chairs, and more than 70 authors. Some of all the glaucoma specialists, Indian glaucoma specialists sitting here, I contributed to some extent. The objective was that we wanted guideline to be specific to the India subcontinent, should be simple, and should be useful for the general ophthalmologist. Of course, glaucoma specialists do not require this guideline, but it should be more specific to the general ophthalmologist. At the same time, there we have lots of guidelines, EGS guideline, we have ASHEP Pacific guidelines, and all are evidence-based. So we also wanted to be evidence-based. At the same time, we wanted to keep some basic chapters which are not in EGS to be useful for the general ophthalmologist. We wanted to cover the secondary glaucomas in more detail, which is not available in some of the guidelines. And of course, Indian subcontinent, we have huge angle closure disease, so we wanted to be more specific to be endoclosure. And at the same time, we didn't mind borrowing some from the European Glaucoma Society and WGA consensus guideline. We adopted some of them directly rather than complicating the things. So see, management goals we know. So and the same principle we try to apply that. So what we did that every chapters also have a concise 15-20 points to be specifically for each chapters. Like for assessment, if people don't want to read and just go through these points, they can understand that what is the important points. So like assessment, very clearly mentioned Goldman apprehension torometry is gold standard. Corneal thickness underestimate, overestimate, but at the same time, written very clearly that do not use nomograms. So gonioscopy is important. Like that, every chapter has a outline, the most important points of the chapter. Same, then we had a risk factor and management principles chapter separately, where we talked about POAG, PSEG risk factor and how to manage. We have taken this from the EGS very simply, and we have acknowledged them. So it was a very nice flow chart in EGS. The target IOP also we borrowed from EGS, which is very simple. So rather than complicated, we just borrowed from EGS that if there is early glaucoma, short lifespan, IOP is high, then you can go for the higher target IOP. So make it simple, use whatever is available, and give a good guideline to the general ophthalmologist. We have surgical options, we had kept the basic surgical part also, though is not required from the guideline point of view. But since it was a first edition, we wanted to cover general ophthalmologists. So we talked about the basics of surgical technique and complications, though in second edition we can remove it. This was first edition, so I kept it. Options. Then medical management, we again this is borrowed from EGS, that how you should start treatment, when you should add, how you should follow up the patients. We have covered how they work the drugs, what are the therapeutic effect of each drug, and follow up. This protocol, this is a specific, we incorporated that if the patient is early glaucoma, stable, then how frequently you can follow up the patient, how frequently you should do the visual field. Again, this is from the EGS. We have just adopted that because it's a very good first 5-6 field in first 2 years, then you can make it yearly. And we also given guideline that if the patient is progressing, then how frequently you should be more aggressive. Adherence issues we have covered. Then we have summarized. As I said that every point, every chapter is a good summary. Then though normal tension glaucoma is a spectrum of POAG, you require specific consideration, and we have tried to cover that in a separate chapter of normal tension glaucoma. PSCD, as I said, is very close to all the Indian glaucoma specialists heard because it's a big issue. We have tried to cover PSCD in a more detail, Then at the beginning, this is something was not given, is that do's and don'ts of diagnosis and management. So if you read this, the basic thing, first 3-4 pages, you get the whole crux of the management part. Like in do's, take detailed history. The asking patient's family history of glaucoma is very important. Asking systemic disease, systemic medication, because lots of things have a relation with glaucoma. Only Goldman, multiple IOP, do CCT, do gonioscopy in every patient, POH is diagnosis of exclusion, always to dilated disc examination. At the same time, don't underestimate, no shiots, no corneal CCT corrected nomograms, no von Erich for angle closure, no for AIOS. So we have tried to cover do's and don'ts. So if you read these first 3-4 pages, you get a crux that how you should manage the glaucoma. Though of course reading the book is more important because it gives a more detailed explanation of each part of the spectrum of the disease and diagnosis and management. So like for that, always use parametry, be reliable, normative. It's very important because now we have lots of machines which do not have normative database. So very few machines have a good normative database for diagnosis and progression. So use that. Always correlate disc and field. Some of the talks already has covered this, but I'm just giving the what we have tried to cover in the guideline. Imaging, then always base progression based on trend and event analysis. Then don't know for imaging. This is very important. No for the imaging for screening and random diagnosis is very important. You get all the red and green disease. So we have tried to cover each aspect of the glaucoma in a guideline. Um, Again, from the management point also, I don't want to go in detail. I just wanted to brief that what you have tried to cover. Uh, Medical management, surgical management, diagnosis, everything has been covered. The Amit has already said that he's going to give the pen drive, but now it's available on the website also. So if you go to glaucomasociety.in, you can download the PDF file very easily. Oh. So Venkatesh is saying that it's already given. And if there's any issue getting the guideline, you can contact me. I will not mind giving you my the PDF version is there. Thank you.
Thank you, Dr. Rajul. And for the pen drives, I would like to acknowledge Sun Pharma for helping us to distribute these pen drives. I thank all the speakers for the wonderful talk. So we start the Q&A now. From the audience, if they have any questions, we can take up the audience questions first. Any questions?
I
from the
have a
audience?
couple of comments.
Yes, ma'am.
I think the ZAP study, Sirisha stopped at 6 years, but they actually have a 14-year follow-up. And at the 14-year follow-up, they've said that the difference between doing an iridotomy and not doing an iridotomy was almost 2/3. So the significance improves as the time of follow-up improves. So I think the number needed to treat reduces significantly if you're going to treat them at around 50 or 55. 55 is the number they've given, but over that. The problem with us is that we see PACS at about 35, 40. Our so-called average life expectancy is 70 plus. A higher socioeconomic life expectancy is now 90 plus. So if we consider that at 40 we are diagnosing PACS, there is definitely, I think, if there is apposition anywhere in the eye, with or without spas, doing an iridotomy has been shown by these studies to be safe. So when we look at the long-term sort of follow-up, I think it becomes a much more appropriate treatment, because you were saying the number needed to treat was almost 40, but actually the number needed to treat even in 14 years has dropped so significantly that if we're going to follow them up for 90 years, it's definitely going to be even better. The second thing with the LIGHT study, I think the LIGHT study also, it said target IOP. It said that, they were looking at a 20% drop. But one thing that they said and people don't notice is that 20% progressed in 5 years. Again, these are people you have diagnosed early. Ocular hypertensives, mild glaucomas. You're diagnosing them at, say, 40, 50, 60, whatever. But they're going to live for those 25, 26 years. So we have to be a little careful when we actually read these papers, that if they're going to progress, 20% are going to progress in 5 years, how many more, or how much further are these going to progress if we are sticking to this SLT, or medications, and the other side we're going into surgery? Yeah, they've said it's a 20% progression, 1 in 5. That's what the LIGHT study says in 5 years. Oh, sorry, 6 years, I think they followed up.
Which I think is scary. We have to be very, very careful. I think PACS, we should be careful, and we should say that, it depends on whether they're coming from a rural area. I see this patient in a very remote place, and the patient is not going to come back. You have a family history of angle closure. You have some risk factors, you treat it. Otherwise, with the kind of rate of cataract surgeries that we have, this patient may not require a PI at all in the future. I'm not contradicting, but I think when this message goes to the public, we need to be careful about doing a PI for every PACS.
So I think during every conference, we used to discuss the same thing, PI and PACS, and what guidelines, we had formed that only the risk factors we should treat.
No, you're absolutely right. I was just saying that the ZAP study, you've stopped at 6 years. So if you actually look at it, for further down the line, it is much more effective to do a laser than without. And in the ZAP study, I think I say this every time everybody talks about the ZAP study, they actually excluded patients who were anyway likely to progress. They said if you have a positive darkroom test, we won't take you into the study. So they excluded those people. So everything has to be taken with a pinch of salt, but the whole thing is, it is safe. So if you think this patient is in the risk factors, don't hesitate to do it. I think that's the message.
Yep. Can I end, ma'am? So the provocative test, the number of patients excluded was only one. Only one.
That's only what David
Only
says.
one.
Oh, he's
one,
the only one who says it. Nobody
Only
else
one,
says
madam,
it.
from 15,000. Only one. So the second thing, ma'am, I'm not saying, but that high risk. But if you look that only 25% progressed over a period of 14 years, and only PSC, no glaucoma. So why to do PI so early? If the patient is coming for regular follow-up, we follow up the patient, and if they develop any point, either appositional closure, IOP or synechiae, we can do it. The only limitation of ZAP is that they had one clock over. That is the only, I would say that is a big limitation. And analysis is much better. So if the analysis half clock over.
So both analysts and ZAP had very stringent criteria, at least half clock hour of synechiae.
No, the ZAP had one clock over.
Yeah. And you
One
excluded high-risk guys. The second thing, I just like to point out that when we looked at a 5-year follow-up of patients with PACS in the Chennai glaucoma study, 25% underwent cataract surgery in that time. So it's very unlikely. Most of these patients are going to have cataract surgery.
You're absolutely right, but I think we forget, at least from our experience in AIMS, is that the lady will be brought to you once. Socio-economic factors are such that if you say this lady is okay, the likelihood of her coming back is only when she either develops a very advanced cataract or a very advanced glaucoma.
But ma'am, that's there in the guideline. If you don't have access to care, we do say that you do the PI.
No, absolutely. So the idea was that it is a safe procedure. Earlier, you and a lot of other people said iridotomy is not safe, be careful, don't do it.
Ma'am, I never said it's not safe. I said there's no evidence that you can use it. Ma'am, I never said it's not safe. I disagreed strongly with the, ma'am, absolutely not. You cannot put words in my mouth.
Ma'am, I think we all agree that in a high-risk group or socio-economic criteria, we should recommend, but not, so I think the message should not go that every PACS should have iridotomy.
Absolutely.
So if there is a socio-economic condition that patient cannot come back or the relative will not bring her, then I think in those scenarios we are safe enough to do iridotomy.
That's it. I mean, I was just saying both
But
large studies have
not
shown
as a
it's safe.
guideline to every patient.
This is mainly the lack of knowledge about the gonioscopy. First of all, most of the people they are not able to differentiate whether it's PACS or PSC. That's the main problem. So we have to insist on the technique of correct technique of gonioscopy so that that's a key here.
If you look the Chennai glaucoma survey, so many patients who were agna closure were actually diagnosed open angle. So that is the main issue, that people don't know how to do gonioscopy. I think we have to more stay focused on and teach them gonioscopy. I think that is more important.
We'll take the next question because otherwise we'll finish all 15 minutes with only angle closure. Dr. Sanjay, welcome to this session. You can come in front. Yeah, you have any thoughts to say?
I just wanted to.
There's a mic. You can come to the podium. So we have Dr. Sanjay Asrani from US.
I agree what has been said. I came a little late, but I just wanted to add, don't forget the risk of vein occlusions from intermittent angle closure. Because whenever you see CRVO or BRVO, there is almost always a angle that is very narrow. So that is one thing that doesn't have a treatment, so we can prevent it.
Sanjay,
thank you.
What's the size of iridotomy now?
Yeah, the size of iridotomy is very important what he talks about. So this is very, very important actually, the size of iridotomy.
Yes, so the paper is just published 2 days ago in AJO, Size Matters. And the size should be at least 200 microns and if possible around 300. For uveitis and diabetics, 300 and others I err towards 250 microns. Site of iridotomy, my preference is always away from the lid margin. That means don't put it at 11 o'clock or 1 o'clock. And you can put it nasally, temporally. You can put it at 4 o'clock, 7 o'clock. Those areas, the lid margin is not going to come in between. And just to prove it, I had a patient who had a laser iridotomy, nasally, no problems, got her cataract done, came back after cataract saying, I can see a line of light. And I'm like, could it be from the iridotomy? And then I realized what it was. She had developed ptosis, and she had a oriental slant. So the eyelid had come down and was cutting the iridotomy. The moment I lifted the iridotomy, the lid, the line of light, she said, is gone. So that proves it, that it is coming from that.
Sanjay,
So just away from the lid
how will you
margin.
measure the size of the iridotomy? That was
How will you measure the size of the iridotomy? So typically I do it with a argon first, unless it is light blue or light green. Almost all others I do with argon. So I know what is a 200 micron spot size because I always start with that to create the well. So then I know if I create a small area in which I put multiple 200 spot size, it's at least 200 spot size.
Helium neon, aiming beam on the helium neon is 75.
So, yes, the other thing to do is, the biggest thing is that after the pilocarpine has worn off, one must check the size. Because with the pilocarpine, all iridotomies will look open and wide. But if it is very narrow or very small, when the pupil is large, then it's not working.
With the Nd:YAG, you're using a helium neon aiming beam, which is 75 microns. So you should see it is at least 3 times the size.
Yeah.
Hello? Oh, okay, great. I do want to mention that the risk stratification of primary angle closure suspects is a very active area of research. It turns out to be a much harder question to answer in terms of who should receive iridotomy, but it actually may be easier to answer who should not receive iridotomy. In the ZAP trial, using a very simple angle opening distance cutoff of around 0.2 millimeters, we can remove about 30% or so of ZAP trial participants who essentially have no risk of progression. And this is because we know that there are certain biometric configurations, such as people with high lens vault, where on gonioscopy you can't see the pigmented trabecular meshwork, but when you image them, there's actually plenty of space in the angle recess between the iris and the trabecular meshwork. So I think in the future, assuming we have access to this technology in our offices, we will be able to at least identify patients who we can safely discharge or at least monitor less frequently.
Do we have any questions from the audience? Okay, I just wanted to ask the panel, since you all are belonging to different institutes, AI and glaucoma. We have some equipments available in the trade now who have AI-based diagnostic machines are available. So do you think we should, our comprehensive ophthalmologists staying in the periphery buy the machine and they can early screen the glaucoma? And what is your view on that?
Actually, we are using our vision center. We are especially for glaucoma and DR and AMD. Diagnosis with the AI is we are almost doing a study to find out the validity of these AI and also with ophthalmologists. Those who are having referred from the vision center with AI diagnosed pathology. In the base hospital, what we see is nearly about 80 to 85% of patients are having some pathology, especially glaucoma and other things. Yeah. The short term, we are doing a study on that. Yeah.
So you can just add a point. Should we be screening for glaucoma? There are two things that we need to be clear about. What are we looking at? We are looking at the optic disc. So is the optic disc showing a change or not? You may be doing that, but you will be significantly missing angle closures, which is a major problem with us. So angle closure, diagnosis, and management is very important. But with regards to the available AI and can we really pick it up? Yes, available AI, some of the AIs are really good. We did check the sensitivity and specificity, and maybe in the next few months, the first paper will be published. It is very good. Early, moderate, and severe glaucomas, if you looked at how the AI is able to pick up, so I think last GSI we had presented that paper, 91% to 98%. So even early glaucomas, the AI, just by looking at the disc image, we are able to pick up. But what is important is in India, you screen, you pick it up, and then do what? So that is a major problem. So we don't have that many glaucoma specialists.
The reason I asked this question was, I get a lot of people, our colleagues from the periphery asking me कि हमको glaucoma diagnosis करने में दिक्कत होती है. So if they have a machine, I'm not talking about angle closure or
I
open
think
angle
Sirisha
now.
is going to tell you about the Kerala model.
Yes,
The
yes.
Kerala
So
model
was 94%. Was 94%. Was quite okay. Was quite okay for a screening tool, because until now I don't think we had the capacity to speak of screening for glaucoma, because diagnosis, the definitions, everything is so vague. But even at least if you have early glaucomas that you're able to pick up, which is 91% sensitivity and 94% specificity, I would say we will not be missing out, or not too many unnecessary diagnoses of glaucoma will be there. But we are coming up with a glaucoma national screening guideline, which I think many of you were part of it. We are finalizing that, and it would be first possibly rolled out in the state of Kerala. Once we see how things are going, then we should try and adopt it for the entire country. I think when we keep saying 90% of undetected glaucoma in our country, we need to move forward. We need to move forward and make sure that at least early moderate glaucomas are picked up much more, and of course severe glaucoma should be picked up.
Yeah, just one comment from Dr. Satyan sir for this topic, and we'll take a next question because we are running late now. We have only 6 minutes left.
The only problem with the AI is when you have machine learning models versus the deep learning models. The machine learning models, it is what you think you try to extract, that is a cup and a disc and the neuroretinal rim, etc. So that is where the problem we have seen. The machine learning model may not be the ideal way, though we have the sensitivity and specificity as 93 or 94%, it is still not enough, because the digital extraction is still not enough. Though we have used the RasNet, everything, but it is still not the best of the things, because what you think as a cup is the area of pallor. But once you start dissecting on the vessel wall, where it is bending and starting as a cup, it is completely different. So we have to really understand, is it ML is enough, or we have to go with the deep learning and then try to understand how best is that we are identifying the cup. Along with that, once you see the RNFL changes, then probably the sensitivity and specificity can be much better than just looking at the ML and saying that the patient has a glaucoma. That is one part. Second part, as of now, whatever the ML or DL model we have, if we can pick up some kind of a glaucoma, then if we can refer it, at least early diagnosis can be much better than missing out everything. A short comment on that. Thank you.
Thank you, sir. I just wanted to ask Mix, Venkatesh sir, the question to you, because you were the first one to start Mix in our country. Arvind Pondi was the first center. Has Mix changed my practice? So what I wanted to ask you is, among all of us, who offers Mix as the first line of treatment? Does anybody in the panel or anybody offers, like Western world offers Mix as the first line of treatment? Have we reached that stage?
Definitely, yes. Yeah, for mild to moderate, and if you are sure it's open angle. Now we do for angle closures also. Definitely, yes.
Before medications. As the first line of
not
management. No, I'm asking very clearly. As the first line of management, do we offer Mix?
No,
as
if
the
there
first
is cataract also, definitely yes.
Okay.
Not if it is standalone, then I'll think twice. No, but maybe in the future we may do, but with cataract, definitely yes.
So how much your Mix has increased and traps have come down?
At least in Tirunelveli, I can say it has crossed 50%. In the other places, it's roughly 25 to 30%.
What about Dr. Srisha at your place?
That's very variable. So for me, if pressures are very well controlled, and if it is both open angle and angle closure, patients are comfortable, no side effect with medications, I don't mind just doing a cataract surgery and not combining it with Mix for everybody. I would say about 70-30%. But in some of the, again, it is very variable. In some of the consultants, even with us, the newer ones are more preferring the mix. Maybe I would say I would put myself in the middle category. You prefer the trabs much more, because that is time tested and we know how they work. So it is variable, but yes, definitely it has changed the practice.
Tarun sir, your traps have decreased and the Mix have increased in aims?
Nothing has decreased, all is on the increase. But my take is that MIGS is very good if you know the limitations, that it is going to reduce IOP by maximum 5 to 10%, and it's good for a mild to moderate glaucoma, and it is going to fail in the next 2-3 years. So if you are comfortable and you would explain to the patient that this may be interim and you subsequently require a trabectectomy, then those patients, I think definitely you can go ahead with the cataract surgery combined with MIGS.
What do you wonder, sir?
Post-operatively, the patients are very...
I wanted to ask Tanuj a question actually. I think we are doing mixed, but not as frequently. Not as frequently. Pediatric actually gets a lot of, those angle-based procedures, GAT and other things. We are doing more of them in the pediatrics, but not for the adult. Adults, I think a percentage is low, maybe about 10%, 20%, perhaps, not more than that. But Tanuj, I just wanted to ask you a question. I mean, your work is very interesting, actually. I'm always fascinated by that. And it looks like that, the underlying autonomic dysfunction is playing a great role, beneath different layers. And what you are dealing with is some way you are altering the autonomic dysfunction. Problem is that it's kind of hard to prove that autonomic dysfunction, that you are doing some tests, especially in the labs, but for a common, ophthalmologist or physician, those are kind of extra things to do. You did mention about the HRV, that stands out from a work that there is one parameter which actually is coming, that I have seen your presentations earlier also, and that's coming again. So can you explain a little bit of the HRV and how do we know and what is this?
Actually, HRV, what is known as heart rate variability, is a very robust marker for the autonomic function. So if your heart rate variability is low, that means your sympathetic function is on the higher side. So now you have all these smart watches where they give heart rate variability.
Okay.
So that technique we just published, 365 breathing, that is very simple. 3 times a day, you reduce your breathing rate to 6 breaths per minute. That is count of 5 in, count of 5 out for 5 minutes. So during that process, if you have a smart watch, you will see the heart rate.
How does HRV basically affects? I mean, what is the relationship?
So as soon as you actually,
what would be the normal? I mean,
so what happens that as soon as you lower your breath rate to 6 breaths per minute, that is the sweet spot where you get the maximum rise in heart rate variability. So any glaucoma patient, especially normal pressure glaucoma, those who are progressing, this is a very easy lifestyle intervention. So not only does the autonomic function improve, but the intraocular pressure also goes down because cortisol goes down. So I think this is something which is very easy, and if 15 minutes a day is not much time.
Can be done easier, because the term sounds like something is more to it, but I think there's a way to do it in an easy way.
Yes.
Thank you, and there's one question to Ronnie, if you permit me. I think you did talk about the structure discordance, right? Is it kind of a normal phenomenon, or is it always abnormal? There's one question, and the other would be that is it because of anatomical variation? Because when you look at the fibers, the nerve fibers on the optic disc, they don't project exactly at the same place in all individuals.
Yes.
So our machines are actually trained to look at the normal patterns, but many individuals will deviate naturally also from the normal patterns. So is that structure discordant because of those anatomical variations, or is it because pathology?
So in my concluding slide, I said the first thing you need to rule out is anatomical variations. And if your defect is actually little peripheral on the disc, it will not reach the macula. So you'll have a peripheral fiber which goes that way, so that will not reach the area which is scanned in the macular cube. So just the absence of structure does not mean that there is pathology. So you might sometimes see it only on the RNFL, and you might rarely see it only on the GCC, but when you see it only on the GCC, look for the temporal raphe sign, because that's very specific. So it's not a,
it's not a pathology.
It's not a pathology in that situation.
Yeah.
Okay. So I think we have come to the conclusion of this session. Any questions can be please taken outside. They already warned us, the alarm is there. So thank you all for attending the session. For those who have not received the guidelines, can collect from the Sunflower representative over here. And I request all our panelists and the speakers for a group photograph over here.